Great. Okay, I'm going to get us started because we have a really important work session today. We need your input. So nurse practitioner Mary Dunn has been at UNC Lineberger Cancer Center since 2010. Is that it? Yeah. Right? You've been there a long time. And Krisztina Emodi is at the University of California, San Francisco. How long have you been there?
8 years.
8 years. So you guys have a lot of experience, and they are both experts in bladder cancer care. And they also, in addition to being nurse practitioners and in charge of patient care, they wear a lot of other hats. And one of those hats is they are the co-chairs of BCAN's Survivorship Taskforce. This is a group that meets online, and they meet sometimes at the annual think tank meeting, our scientific meeting. And they have been working with this group to really find and define what is survivorship and what tools help patients, and how can their facilities where they're being treated provide those tools so that patients have handy hints, tips, suggestions, documents to keep track and keep moving on their bladder cancer journey. So I'm really delighted to turn this next session over to them, and they are going to ask for your input. We're going to take some notes, and there are going to be some opportunities, I believe. Don't we have Slidos?
Yes.
At the beginning. So take out your phones again.
Here we go. Intro, and then we'll. So I'm gonna fall.
Just don't trip on that.
Okay.
That's all.
All right. No tripping. All right. Hey y'all. So glad to be here. I'm Mary Dunn. I'm a nurse practitioner at UNC in Chapel Hill, and I do wear many hats. I tell people I have the best job in the world because I get to do both urology and medical oncology. So I wanted to thank whomever put the program together for using a picture of me that's a solid 15 years old so that everyone can see how much this has aged me. So thank you to whoever chose that picture, and sorry if that's the one I sent you, was not intentional. And also thanks for putting us like right after that amazing panel and right before happy hour. So for those of you who stuck around, thank you in advance. Very much appreciate that. But wholeheartedly, thanks for having to BCAN, everyone who worked so hard to put this together, for having survivorship on the big stage. This is a topic that is near and dear to our hearts, and we've done a lot of work, but we have a lot more work to do. And looking forward to y'all's input this afternoon or evening or whatever time zone we're in right now. I think I've got one-ish intro slide, and then we'll do poll questions. Is that the one-ish intro slide? So yeah, clearly I'm doing my job very well. So thank you, first of all, to those of you who filled out the pre-meeting survey. I think there's about 42, 43 of you who did that for us. Thank you so much. We sent that survey out earlier this year prior to the think tank and wanted to get more involvement from folks who may not have had a chance to fill it out at that time, because we're trying to get a lot of different perspectives so that we can narrow down the focus of our survivorship work on the task force. So we want to get a sense of your experiences. So we have a few polling questions that Krisztina is gonna go through with this fancy schmancy tool, and then we'll kind of talk through some work the task force has done, and then hopefully make this as interactive as possible is the goal, because we want to hear from you. All right. Try not to strangle myself. There we go. Okay. Thanks. Thank you. Welcome.
Hi, everybody. I'm Krisztina Emodi from UCSF, and as Stephanie said, I've been in urologic oncology for 8 years. I completely accidentally dropped into this field, but I don't think there's anything accidental in life. I ended up interviewing at the VA for a part-time position, and the next day I got an email from our department chair at UCSF, who happened to be on that panel, that they need me at a different facility full-time. So initially committing to 2 years, and now 8 years later, I fell in love with my patients, my colleagues, just the entire journey and the complexity of this journey. And through my incredible mentor, Seema Porton, who many of you might know, many of you don't know. She's my, I don't even know, I get goosebumps when I think about her. She's a phenomenal, amazing human being and surgeon and friend. So I wouldn't be here without her today.
Member of the BCAN Board of Directors.
Yes, yes. So anyhow, that's in a nutshell where I'm coming from and standing with this journey. So if everybody could get their phones out and log into scan the barcode, I'll give you a minute so everybody's on the same page. And we are going to be focusing on some 7 exactly questions that we wanted to ask you and have an input from a survivorship perspective. Are most of you ready? Yes, thumbs up. All right. Oh. So the first question is, as Stephanie and many of us asked you before, when you think of the term survivorship, what's the first thing that comes to mind? I know, the answers just keep coming in. So we're at 61. Anybody else is not ready yet? Okay, so look at those wonderful answers. It's anything from living to being a fighter, if you're still alive, being strong. The TV show, I want to hear about that. Oh yeah, the Survivor TV show, I got it. All right. It took me a minute.
There's someone funny in the room.
I know. So anything from overcoming, obviously, obstacles, being a warrior, aren't you all?
Beyonce's up there too.
Oh, oh, Beyonce. Okay. I want to hear about that story too.
It's a great song.
Yeah. Obviously, your grandchildren probably living for family, staying alive, and just really having the courage, I think, to face all of these obstacles and challenges that you have throughout your journey. The next question is uncertainty or worry related to your cancer experience is something that you identify as a survivorship issue. Okay. Numbers are still going up. Okay, we're at 42. Okay, we're at 49, so clearly the majority of people identify as potentially worrying about your cancer experience or uncertainty related to diagnosis, uncertainty related to recurrence or just the journey is something that is an important part of your journey. And the 4% of no's, I would love to talk to you also, maybe not sure what is it, the mental health component that came from the previous conversation. So I think this slide also clearly speaks for itself. So the third question, do you have treatment-related side effects that you address with your provider during your visits? Yeah, so that relates to during the time when you were under treatment, this was something that was discussed during your visits with your provider. Well, do you have treatment-related side effects? So that basically can be during your treatment, right? Or in your survivorship, however that's defined. I think even the definition, we are still trying to figure it out, what it means.
This is just a thermometer of what's going on in the room.
Yes. Okay, so 74% of you, we have 54, 55, what's coming in. So looks like 25% of folks, 24, didn't really have that kind of a conversation.
Yeah, that needs to be 2 questions. Did you have treatment-related side effects? Yes. Did you address them with your provider? No. You know what I mean?
Yes.
So I said no, because I didn't address them, but yeah,
But so I think the way we meant to have the question, that during the time when you were under treatment, if you had treatment-related side effects, whatever that was that discussed during your visits with your provider? Right, Mary? I mean, I think that's what,
well, that was again the two-part question. She did have side effects, but she didn't discuss them.
so that's a no. Yeah. So it looks like majority of folks have opportunities to talk with their providers, and hopefully those issues were addressed. It's still obviously 20% of people did not. That is a big number for undergoing this type of a journey. Okay. Another's okay. Thank you for the feedback. Okay, next question. Okay. Hopefully we got this right. Is sexual health a topic that should be addressed during your post-treatment surveillance visit? Very important part of quality of life. I have to tell you that during post-operative visits or follow-up survivorship visits, which again, however we define, I think generally defined as somebody being out of surgery potentially for muscle invasive situations, 3 months. However, there's lots of non-muscle invasive cancers. Still, you have sexual side effects as it relates to intravesical BCG, gemcitabine, doxytosol. People have lots of questions that need to be answered regarding intimacy during BCG and actually protection, et cetera, that oftentimes is not necessarily discussed. I also feel that during my visits in survivorship, my job is to plant the seed to start the discussion and keep bringing it up in visits. And so when people are ready to kind of more engage in a topic, when you're ready physically, psychologically, then we can actually talk about it. If I don't bring up this in my visits or conversations, I would say the majority of patients will not. So I find it very, very important as a clinician to pay attention to this and assess where we are and how important it is for you. I have patients that it's not important at all, and I have patients that are wanting to have an erection with a catheter. So we are basically having a full spectrum of what people's needs are. All right. Next question. Do you have a clear understanding of what your follow-up visits entail? So this is usually, and I think the app will be very helpful for this when it's coming out, what scans you need, blood work you need, whether or not you need urine cytology, further cystoscopies, any other referrals to other services. So we have 45 answers so far. Looks like the majority of you have a very clear understanding. I think sometimes it's tricky, but I often hear feedback-wise, if orders are not in on time, you don't get a call immediately post-visit when your next follow-up is due, whether that's for scoping or whether for a CT urogram. So people generally like to have all their orders in, for example, before they leave the visit. So when you leave, you actually have a plan in place that is clear, and you can mark it in your phone, mark it in your calendar, whatever that is. Okay. Next question. Do you have someone you identify as a caregiver who has been part of your cancer experience? Okay, we have 44 answers so far. Okay. So 53 answers. Majority of you have someone you're able to get help from and rely upon to whatever capacity that is. I think 7% of people not having that in their lives, even within this community, that is a big number, because everybody should have someone to be connected to and rely upon. So again, during survivorship visits or communication with your provider, for us to actually understand that it took maybe 5 hours and 3 friends to get you to that visit where you are, or financial burden or toxicity or whatnot, those are not oftentimes brought up during visits. Okay. So I think this is our last question. Thank you for bearing with us.
Is there going to be one like, who do you favor in the World Series?
Who do you favor in the World Series?
Who do I?
Yeah.
Oh, boy. Arizona.
Good answer.
Am I on your good list now?
All right, so last question, folks. Thank you for answering. We have 40 answers. As a result of your cancer experience, have you received care for your mental health? And I think that beautifully ties back into our last conversation with our team. Okay. So majority said no. I think maybe this question could also be dissected from a binary, whether or not you actually had no mental health related side effects as it related to your cancer journey, or you had side effects but you actually didn't seek care, versus people who had a need for counseling or medication management actually seeked care, right? So 36%, that's 64, is a big number, but I don't know necessarily if that's a big number and it's a wonderful news because you don't need anything, or versus you actually didn't have the courage or the resources to ask for it, right? Okay, survey's over. I'm handing it over to fabulous Mary, and we are moving into our survivorship work.
All right. Thank you, Krisztina. Thank you all for your participation. So, like Stephanie said, this was to kind of gauge kind of the temperature in the room, and what these answers will help us with, like feedback from you all is super important. It will help us design future surveys so we can get to a more like granular level on very specific topics. So your feedback is very important because these are just questions that I threw together, right? So your feedback is important because you're the one living it. So thank you all so much. So this is a definition that is of survivor that is pretty widely accepted. I'll read it to you because I think it's an important statement. So an individual is considered a cancer survivor from the time of diagnosis through the balance of their life. Family members, friends, and caregivers are also impacted and therefore included in this definition. So the definition of cancer survivorship has really evolved over time. It used to be very narrow. We would use definitions such as a person has to be, 5 years post-treatment cancer-free, and didn't mention anything about caregivers, friends, loved ones, anything like that. So we're kind of widening the definition of what is a cancer survivor, but I still think we have a lot of ways to go here, and this is where your voice is going to matter. So we know that survivorship means different things to different people. For some people, it does mean having no signs of cancer once you're done with treatment. That's fine. Some people really relate to that more through the lifespan definition of survivorship. So with, through, and beyond cancer. And then there are certainly others. And of note, that term survivor or the survivorship doesn't always feel right to everyone, right? So some people who come to my clinics, and we call them survivorship clinics, they have told me, I don't want to be labeled. I don't want to be identified in such a way. I don't always want to have something that attaches me to my cancer experience. So I will be the first one to stand up and tell you, while survivorship is something that I'm very passionate about, your cancer experience does not define you in any way. We are all complex human beings. Being a human is complicated and complex. Cancer is just part of your story. It's not your entire story. So I just want to make it very clear that when we're doing this work with survivorship, that we are not trying to pigeonhole anyone into one certain thing. We use these terms broadly. So I just want to put that out into the atmosphere. And then there's individual challenges and concerns among the whole spectrum of cancer care. So we're trying to kind of narrow down our focus of things that we would like to work on as an organization, and with our partners at BCAN and with all of you. So this is just some general cancer survivorship data. I think this is from 2022 last year. So there's over 18 million people with a history of cancer in the United States. The number of cancer survivors is projected to increase pretty significantly by 2032. These are pretty stunning numbers, right? So in the next 10 years, the number of people who have lived 5 or more years after their cancer diagnosis is projected to increase approximately 30%. So what does that mean for our work in this space? Well, it means that we're going to have a lot more people who transition into post-treatment surveillance and survivorship care. And we, on this side of the street, need to have a better understanding of what that looks like for people, and we need to do it better. And we also know that the population is aging, and that 67% of people who have a cancer experience are over the age of 65. And with that comes other comorbidities and other things that we need to be mindful of. So this is a serious work in progress. Now, I know that in this room, we could probably spend a solid hour dissecting every one of these words, but we're not doing that today, okay? We're not doing that. We're not doing it. This is a work in progress, which is why it is in red, okay? What we are going to do is I want you to look over this. I want you to think about it. And when I'm done running my mouth, which I know most of you probably hope it's real soon because we're counting down to happy hour here, but this is a work in progress, and we want input from different stakeholders. So this is a priority for BCAN because we think that this blanket term for survivor, or however you want to identify yourself, or not at all, is really quite broad. And we would like to, as a team, come up with a recognized definition that includes the nuances that comes along with being someone who has had a bladder cancer experience, whether in the past or someone who's currently going through treatment. So this is real vague. Okay, so take a picture of it, think about it, and then when I'm done talking, we're going to take a lot of notes here. We'll take a lot of notes because that's all I do is scribble stuff. And I want your input on, and you can also email me. I'll give you my email. That's fine. About what doesn't make sense here. What are some things that could be included? This can't be like a thesis. Okay, so we got to keep it relatively short. But with your feedback, we would really like to make a definition here. So this is why we're bringing this all to you, because your input is so crucial here. So thank you. And if you're judging what I threw together, please do keep it to yourself. Okay. I am the middle child. I have big feelings. Okay, so I'm hearing things over here. I'm hearing things. All right. So why am I here? For heaven's sakes, why am I here? Well, it's because I don't think in the over a decade I've been involved in BCAN that I've ever told you no to anything. So first of all, we need to work on boundaries here. But secondly, this is such important work, and I think BCAN is really passionate about really putting survivorship at the forefront of getting some research projects off the ground. So I'm here because I can't tell Stephanie no, and we've been doing some work the past couple years at the think tank, myself and Krisztina, along with a lot of other people, and lots of people in this room who are on our committee. Raise your hands if you're been part of this task force in any way. I know some of you are here. I know you're here. Thank you guys. So what did we do with the 2022 think tank? So for those of you who are not sure what the think tank is, that's Beacon's annual scientific meeting. It's my favorite meeting to go to because it's this beautiful blend of healthcare providers, researchers, our industry partners, patients, and caregivers. And it's always a good time too. So prior to the 2022 think tank, we sent out a survey to everyone who was going to be attending the think tank. And then we had a breakout session. So there's like big stage sessions and then there's breakout sessions. And we had a survivorship breakout session where we reviewed results from the survey I'm sorry I tend to lean this way. I am not trying to ignore this side of the room, sorry. So we reviewed the survey results, and what we did was kind of go through some of the questions, one of which was we were trying to identify how different groups view the most important survivorship needs. So we had people let us know, are you a healthcare provider? Are you a patient? Like lots of little demographic type stuff. And then what they thought were the most important survivorship issues that we could think about future projects for. So we got a lot of uncertainty / worry related to recurrence, post-treatment related side effects, and then emotional and mental health were kind of the top 3 things that came out of that part of the survey, which was not surprising. And then we talked a lot about how are we going to shape the future of survivorship focused research. And we kind of gave people a list of things and then a space to kind of write in their ideas too. But the top 3 things that came out of that question was talking about specific bladder cancer survivorship clinics, incorporating support groups more into the post-treatment phase of the cancer experience, and also survivorship care plans. Now, has anyone in this room received a survivorship care plan? Please, God, one person raise your hand at least. Anybody? Someone lie. One person just put your hand up and lie. Thank you, Karen. I can always rely on Karen. Thank you for lying. Okay. Oh, this is being recorded. Sorry, Steph. Okay, since heaven, we have a lot of work to do. So much. We have so much. We're like, just like at that. Yes, that's what I have to do now because no one has received a care plan. Okay. So I'm making myself a list and this. Okay. So a survivorship care plan is designed to be a relatively brief yet comprehensive document that kind of details what a person's cancer experience was. So it has your basic demographic data on it. It has a list of who was on your care team. So whether that's surgeon, radiation, medical oncology, advanced practice provider, et cetera. And then it lists what treatments you've had, whether that's BCG, surgery, chemo, all the things. And then it should have also what your post-treatment surveillance schedule is going to look like, which is just a framework, right? That can always change, and what's going to be done at those visits. And then a lot of care plans also incorporate a lot of other things related to, these are based on what treatment you had. These are some potential late and long-term side effects from your particular treatment, and it lists things. It also lists things like, this is actually a normal thing that's going to be happening. Resources where Beacon's on ours, the one that I helped develop at UNC. And it has resources about emotional and mental health, nutrition, well-being, all that kind of stuff. And an important factor here is that this not only should go to the patient, but it is a communication tool that we on the cancer side use to communicate with your primary care providers. Okay, so this is going to be my plug. Everyone needs a primary care provider. If you do not have one, put that on your list of things to do on Monday. Okay. So this is important because in the post-treatment phase, a lot of times there's crossover between like who is doing what. Is the oncology team doing X? Is the primary care provider doing X? Should I be talking to my patient about colonoscopy? Am I turfing that to primary care? So it's a communication tool between cancer team and primary care, but also a document for patients to have, which you can get through your MyChart portal. We can print it out. We can do all kinds of things. So cool, lots of work to do. Thanks, y'all. And thanks, Karen, again, for being my scapegoat. Okay, so what happened after 2022? Well, my hair turned gray and I had to dye it after learning about all the things that we were not doing well in the survivorship space. So how can we do this better? So we decided to form a survivorship task force. So after 2022, we had 5 meetings to review, share ideas for how the Beacon community can meet the needs of patients who've had bladder cancer, identify gaps, of which there are many that we are learning about, and discuss projects. So folks who were part of that breakout session, so this is a team of providers, patients, caregivers, advocates. It's a very diverse group of folks. And as part of in between 2022 and 2023 think tank, we developed a provider and patient survey. So this time we broke up the surveys, sent one out to the healthcare folks and one out to the patient folks, which helped us narrow down our focus of what we wanted to focus on for projects and research and things like that. So that was kind of what happened in between. And again, several people in this room have been instrumental in making this work move forward and also keeping me focused, which is not a task anyone gets paid to do. So what is the Survivorship Task Force? So we kind of came together and formed following the think tank. I just went through all of this, so I'm not going to read you this slide again. What is wrong with me? So what did we do at 2023 think tank? So that was just in August, which feels like eons ago at this juncture. But we again reviewed the survey data that we sent out ahead of time. So we had 80 healthcare providers, so advanced practice providers, which are physician assistants and nurse practitioners, our physician colleagues, so urologists, medical oncologists, and radiation oncologists. And then we had a patient survey. The patients who filled out the survey rocked it. You kicked the healthcare providers' butts with the numbers there. So thank you guys for always being on top of stuff. And we looked at all this data, and there's so much to take away from this. So then, of course, my mind starts going, and then people have to reel me back in, and that's always a fun task for everyone. But we came away with several really important takeaways from the surveys that we sent out. And in fact, if you were one of the people before this meeting that took the survey that Patricia sent out, it was this one. It was this survey. So thank you for continuing to contribute to this work. So from the provider standpoint, what we learned, some of the major points were that providers are really interested in learning more about and possibly implementing bladder cancer survivorship clinics. So a dedicated space or a dedicated clinic where there's an expert in bladder cancer who is managing patients who are right now kind of focusing on post-treatment. So it's not, right now, at least in my practice. So it's funny. I work very closely with Angie Smith. It's funny, like my partners at UNC think I run our bladder cancer survivorship clinic. We don't have a bladder cancer survivorship clinic. So they give me way too much credit, but I was like, y'all, we need to talk. But a lot of people are really interested in this because folks who've had a bladder cancer experience have a lot of needs that are very unique. And different than people who have had other cancer experiences, which I learn about all the time. The providers identified potential barriers. You are all very smart people. I'm sure you can figure out what all of those barriers are, but it's the same barriers that we face with basically everything we want to do to make patient care better, which is time, space, support, all of the things, knowledge, right? So not everyone is an expert in post-treatment survivorship care. So lots of barriers. And they also listed a lot of potential benefits. So folks were excited about, yes, maybe this focused care could end up in better results long-term for our patients. And they also acknowledged that advanced practice providers, so nurse practitioners and physician assistants, could play a really key role in this space, which of course, as one of those people, I identify as an APP. I think we do a really nice job in this space. So there's lots of takeaways here, but our patients on the other side of the survey, I don't know why this bothered me so much. Is there was a question about it was a, I don't know, 8 or so list of things of very specific resources. Are these things available at the institution where you received your cancer care? And there was 40% of people who answered the survey did not know about any of those things offered, or if they were offered. I'm like, oh my Lord. So we have a lot of work to do with making sure that the things that we have, in order to provide holistic care throughout every step of the cancer experience, that patients know about that. I'm very lucky at UNC that we've got a wonderful patient resource center. So all I have to do is say, you're on the second floor now, go down to the ground floor and go see the nice people in the patient resource center, where there is just a wealth of things about what our institution has to offer for things like wellness and mental health, nutrition, and all those things. I recognize that those things are not offered everywhere, but it was a little jarring that a lot of people didn't even know if anything was offered at the place where they receive their care. Patients love access to telehealth. We found out. Who here has had a telehealth visit or a virtual visit with your provider? Yeah. Who liked that? Yeah, it's convenient, right? So if you're not having an acute issue or need someone to lay hands on you, it's a really nice thing. So we're thinking about that kind of in the post-treatment survivorship for folks. And then a lot of people had no idea if their institutions had bladder cancer survivorship clinics, and that's okay. And a lot of patients found a lot of comfort and community and solace in support groups. So those were the big takeaways from those surveys. Again, thank you for those who participated. So this is what I called like the hot topic discussion items that came out from that session. There was a lot of really great discussion. So one of the main things that we want to do that Stephanie and Mark and Patricia are so supportive of is creating a space on the Beacon website for survivorship that currently does not exist. So I have wonderful people who are who volunteered to like glean what's already on the website so that we know what's there and we can kind of move into a separate category, and also so that we know what things we need to develop. So once that is up and running, everyone will be notified, because I'm going to make sure everyone knows about it. There are bladder cancer specific survivorship care plans that exist on the planet. This is not a new thing. One was developed like through Beacon several years ago. It's been a while. So what we're going to do as a task force is kind of look at what's out there and see if it needs to be tweaked and honed, and then make sure that there is a survivorship care plan that's been vetted by professionals and vetted by Beacon that we can have available on the website for kind of two different things. So for patients to have access to say, hey, this is something I would like to have, take it to your provider, and for the healthcare providers to have access to say, oh, this is something that that we don't have at our institution, and this is a good framework. So how can we incorporate that into our patient care? We'd also are going to work on some guidelines, which I think I have a slide about that. We're going to talk about doing some work in the smoking cessation space, and then looking at gaps from our survey, not only the one that people have already taken, but the one from today, because there are still like they're broad questions and then more specific questions that we would like to get answered. So our current action items, so for the website, we're going to have patient and caregiver subcategories. We're going to have a healthcare provider subcategory. And like I mentioned, I have awesome volunteers who are going through existing resources, and then we will create more for that space. And like I mentioned about the survivorship care plan, really just updating, not reinventing the wheel, but updating current iterations of what we have for providers and patients to be able to access as part of the survivorship space on the Beacon website. And then in kind of looking at survivorship guidelines and standardizing bladder cancer survivorship clinics. So when we're talking about guidelines, what we're thinking through is like a 1 to 2 page document for providers that really goes beyond I don't know how many of y'all are familiar with the NCCN guidelines for follow-up. Very easy to access. You can see kind of what experts have put together as far as like, if this person had this kind of cancer and this kind of treatment, this is what we recommend for their follow-up. That's great. We appreciate that. But I think that guidelines for post-treatment survivorship for bladder cancer we've talked about this in a lot of our meetings, really need to go beyond when is your scan, when is your cystoscopy, when are your labs, see you again in 6 months. That's not enough. We need to be talking about, the things that are listed here: health promotion, disease prevention, long-term side effects, and just having some data around those things so that healthcare providers can access that information as they are working to kind of standardize their survivorship post-treatment care. And then documents that we know need to be kind of developed and honed. And we had this is a beautiful transition from our last session into this, because there is so much that patients need and want about their emotional and psychological well-being, whether it's at the time of diagnosis, during treatment, post-treatment, at the time of recurrence. I was like jotting down some of the papers that that the awesome panelists before us put up, because like some of this data already exists. We just need to figure out how to put it in a place, and how to really be able to assess this well during visits. And I think someone, I'm not sure who that person was, sorry, I was sitting back there, mentioned about incorporating psychiatry or psychology or our mental health colleagues as just kind of like standard of care at the time of diagnosis. Lord, that is a hill I will die on. Everyone needs a therapist. The therapists need therapists. Everyone needs therapists. And I think, I'm not an expert in that, right? Like, I think we on the, oncology and urology side, try to recognize where our limitations are. So, when I ask people very open-endedly, how are you doing with the emotional aspect of where you are in your cancer experience right now? And they burst into tears. Well, that's obviously something that I need to refer. I'm always happy to listen, but I'm not an expert in how to manage those things. Part of the problem, someone was mentioning barriers there, is that there are not enough mental health providers to meet the demand of not only patients who are going through or have been through a cancer experience, but the general population. It is a real problem. We've got a great program. I can speak to my own institution at UNC, but they are so stretched right now that they can't right now see patients unless they're in active treatment. So where does that leave my patients who are having sleepless nights because they're worried their cancer is going to come back? So we've got to figure out a way. I want to fix all the things, but it's a marathon.
One thing to comment on in my practice, very similar to Mary's, people come very far to academic medical centers for your maybe initial evaluation. You do your chemotherapy locally with your medical oncologist, but the big oversight is still under our institutions. And I try to establish some kind of a framework as soon as I can, because it's very difficult to get into these practices, but now with the availability of telemedicine, actually there's really no limitation, doesn't matter, well, as long as you're within state. So for example, in the state of California, unfortunately, we are limited to only be able to bill for visits within California. I can only prescribe in the state of California. And I know in our think tank meeting, there's something that we want to take in front of Congress to actually allow providers from across different states, patients able to access anybody who they need to in their care team. I generally put in a psycho-oncology referral at UCSF, and that is same thing. I'm asking very simple questions. I'm usually starting with the sleep question, because that's huge. If you don't sleep, I mean, It's like I remember having a new baby, and by 6 weeks I was losing my mind from sleeplessness. But because it takes time to establish these relationships, these referrals are going in immediately, and you're set up with a therapist who is working with cancer patients specifically. Once these folks potentially graduate you, and you are in survivorship, so again, cancer-free, whatever that timeline is, having your first scans, everything is disease-free, then at UCSF, we actually have an opportunity to transition you into survivorship wellness. And those are professionally ran groups weekly on Zoom, available to anybody within the cancer center. They're not specifically bladder cancer focused, but the point is they still go through the motions of nutrition, of whatever, sexual health, exercise physiology, etc. So each week you actually have a well-mediated session with a professional. And so all we can do also during these visits is actually offer you the resources and set you up with it.
That's great. Thanks, Krisztina. I think that was all.
Go ahead. Question.
Hi.
Curiosity question. Have either of you met with a therapist or group therapy or therapy group that, due to all the paperwork that's required through Medicare, you turn 65, can't see you on it? That happened to me.
Oh, I'm sorry.
And I was doing the best work I've ever done. And it was devastating.
That is not a specific scenario that I personally have run across, but I wouldn't be surprised if it's common.
I mean, she was a private, well, I think my voice is loud enough. She was a private provider, so it wasn't part of like a university hospital cancer center or something like that. And her point, and I mean, I kind of understood it. She said, I'd rather spend more time working with patients than filling out paperwork for Medicare.
Yeah. Yeah. Thank you for that.
It blew my socks off.
Yes. Thank you for that. I think you bring up an important topic, writing this down, about kind of outside of the academic medical centers and private practice. Their private practice mental health facilities, clinics, providers, what have you, that that oftentimes don't take insurance for a lot of reasons, or don't take Medicare because of the enormity of the red tape that comes along with that. That sounds like a fun thing to talk to Congress about. Add that to my list to email later today.
I worked in Congress, so I have some connections.
Although I'm pretty sure my email is blocked from my local representative, so I don't know how far I will get. It's fine. I don't even care anymore. I'll tweet at them. It doesn't matter. Thank you for that. I mean, that is an extraordinary barrier that in my mind, without understanding all the nuances behind that, is completely unnecessary. But you've just identified something that I hadn't thought about, so thank you. And I'm sorry that was your experience. Did I move ahead too fast? No, we talked about all that stuff. Y'all want me to go back and repeat the whole? No, we won't do that. Not going to do that. So those are short term, which to the folks who are helping me with this, again, thank you, because I know it's a lot. But longer term, what are we thinking about? Because this, there's a lot of work to be done in this space, and we're all, we're volunteers doing it. So we have to kind of think in smaller chunks than reeling me in constantly. But, just things like Stephanie actually identified this one for us. So like developing an icon for survivorship documents that already exist on the BCAN website. So they're identified as such. So I think one of it was a life preserver or a life raft. A flotation device of some sort. Yeah. You did. I liked that. Expanding our task force. So everyone is invited to be on the task force. I promise it is not like this all the time. So if you would like to be a part of this in any capacity, if you can't join the meetings, it's fine. I'm happy to like talk back and forth. We usually meet quarterly. Please see me so that I can get your email. We don't email a ton, so it's not a lot in your in basket. But if you're in the least bit interested, we'd love, like, this is an ongoing group. Thinking about how we're going to disseminate this work once we've got some more tangible stuff, I think is another big picture. Narrowing the focus of future surveys, which I've touched on. We want to have a task force meeting with that social work group that I think Steph alluded to in the beginning. The social work group who's partnered with BCAN, because we're curious as a task force, like what they're hearing on their end of the phone, because they might be hearing different things. The cancer care group, thank you. what they might be hearing on their end of the phone, that we can like work together to incorporate better survivorship care. And then eventually, someone will write a paper. Brennan's going to write the paper for me because I'm not here for that. Volunteered you. Not a good writer. So I'm thirsty, and that's my last slide. So I meant water. Hang on, water. This is not vodka. I heard that. And it would be gin if it was. So I know I went through that very quickly for many reasons, but I wanted to leave. How much time do we have for questions? Up to half an hour. Up to half an hour. So and if you need me to go back to a certain slide, but we really wanted to have time to hear from all of you. And this is the space for it, because we want to hear what your survivorship thoughts are. And again, like, not just post-treatment, for those of you who are actively in treatment, for those of you who are living with advanced or metastatic disease, your voice matters in all of this too, because we are going to tailor this to everyone who has a bladder cancer experience, regardless of where you are in that experience. So please don't feel like you have to be not getting treatment right now in order to be included here. This is all inclusive, and it's very important. So we would love to hear from you. Now, if no one has any questions, just because everyone is like really aching to get to the gin, that'll hurt my feelings a little bit. So I planted people. No, I didn't plant anybody in the audience. But we do want folks to use the microphone as this is being recorded. And
it'll help us remember everything.
and it'll help remember, and we gotta, something to jot down.
I'm the
on.
transcriber.
Do you want to be the transcriber? How's your handwriting?
I don't know.
We'll find out. We'll find
Okay.
out.
Do we have a pretty handwriter?
I have a microphone.
Have
There
you
you go.
looked at any of the organizations like ASCO or NCTN for their best practices?
Yes, thank you. So NCCN has survivorship guidelines. Like, they have a whole, so they've got the, by the cancer, but they also have survivorship guidelines. They have all kinds of guidelines that aren't like cancer specific. So they do, as does, I believe ASCO does as well. So, we're not gonna, we don't want to reinvent the wheel. But we do want to make what we are doing bladder cancer specific. Yes, thank you for the question.
Yeah. Also, the American Cancer Society. So we kind of need to look at multiple different platforms. For example, I get questions about colonoscopies all the time. People feel uncertain whether or not they need one, especially post-cystectomy. Having a conversation that we actually only resect the small bowel, nothing's happening to your colon. You absolutely 100% need your colonoscopies on a regular basis. I had a recent patient who had trimototherapy, so she got chemotherapy, then radiation. She kind of graduated somewhere else and came back to us, and this was 7 years ago. Not a single time she had a colonoscopy. Never even a fecal occult blood test. It was just kind of an untouched area. And as we know, colorectal cancers or anything posterior anterior to the bladder, that has to be monitored. So I think within these guidelines, also just looking at secondary cancers as you're moving forward in your life is very important to address and be part of your care plan. Right?
This is a kind of a lead into what you just said. I'm a triple cancer survivor, bladder cancer being the most significant. Three totally separate tumors, lung cancer, and then melanoma. And so what I'm concerned about is, does that predispose me to need to monitor certain things? You mentioned colonoscopies, that one I'm aware of. But are there other things that I should be aware of? Like, my primary care doctor is, she said you need to have a higher vitamin D level, and she's concerned about immune support. But I would kind of, from my perspective, I would like to know, what else should I be monitoring or focusing on, or Or do I just do the regular things that come with aging, or does this cancer history, how does that impact what I should be monitored for, or what I should be aware of in terms of my own, health advocacy?
Yeah, so I think that's a wonderful and very complex question. This is where your individual care plan would, come into place. Again, I think depending on history, I don't want to comment on lung cancer because we are so highly subspecialized, for example. But for example, a lot of my patients who have had undergone chemotherapy or radiation, some of the most common things that I ended up working up as a provider is actually lymphomas. So if we, for example, see enlarged lymph nodes on a scan, we don't want to jump on a boat like, oh my God, this is automatically bladder cancer recurrence. It is not necessarily. And so I've seen that now enough times that unfortunately I see secondary cancer developments, such as lymphoma, that is fair game to actually watch for. For most of it, actually, we are just watching people and you actually don't need necessarily treatment. But that's one of the cancers, for example, that absolutely can come up on your scan.
No, I wasn't asking you to comment on me exactly.
No, I
But
understand.
I just wanted to,
Yeah.
to suggest that as a concern that other people might have as well. Now that I'm a cancer survivor, what do I do besides
Right.
being concerned about recurrence in these different areas?
Yeah.
What else should I do or pay attention to?
That's a great point. Thank you so much for sharing your experience. Gail, are you adding to
Hi,
my
Mary.
list? Hi.
Hi, Mary. To answer her question, I would probably suggest that she's had multiple cancers, that maybe genetic testing is good for you. Okay, because I did too, and I've had endometrial cancer, bladder cancer, upper tract cancer, and then 6 months ago I went for my normal colonoscopy and upper endoscopy because I'm a Lynch syndrome patient. If anybody knows about Lynch, it's a cancer. It's a cancer, a genetic cancer type syndrome. And what the doctor found was an extremely large polyp, but took it out. And it came back as positive for adenocarcinoma, number 4. So, of course, he took it out, and I'm going back next week, and that's 6 months for another colonoscopy. So I'm one of these people that's get it done. Get it done. If there's nothing to be afraid of. And I've heard this from people before, they're not going to have a colonoscopy done. I've never had it done. Yeah, I'm 80 years old. I don't care, et cetera, et cetera. And, and if you really, really want to stick around for a while, and you don't know what your genetic makeup is, check your genes and follow from there what your doctor says.
Gail, I'm sorry that's just one more thing on your plate. Thank you for, yeah.
The way I look at it is, with Lynch syndrome, it wasn't a matter of if, it was going to be a matter of when.
Do you know, as part of your post-treatment surveillance, survivorship for all of those things, are your different oncologists in communication with each other?
I have my uro-oncologist at Hershey, and I have a GI doc and a doctor who does the colonoscopies and upper endoscopies. And since they work out of the same hospital, I'm hoping they're in contact with each other.
That's fair. Team communication, I'm going to put up here something for you to remember. Who else?
My questions seem so
All right,
trivial after
where?
those
There you are.
after those serious situations. I would love to see Beacon put kind of like how to maintain your car with all the complications after cancer. I haven't found anything on our website for Beacon about hydronephrosis. I have in both kidneys, and a lot of people have that, I think. Maybe not. Or strictures in the ureters where you get to have stents exchanged, and all the complications that come like from just not metastatic, but it'd be great just to, so you wouldn't have to nag at your doctor saying, you know, these are minor, but what can I do about them? And there's a lot of talk about metallic strictures causing some problems, and, you know, going for surgeries for all these little, like, checkups at the auto repair store.
Thank you.
And on the website, on Beacon's website,
Yes,
they got
ma'am.
all the serious stuff.
Well, those things are also serious. Those are significant quality of life issues if you require stents and nephrostomy tubes, and yeah, let's not minimize any of this. That's a significant quality of life issue. Yeah.
Hi.
Hi.
After my surgery is the first time somebody mentioned peristomal hernias,
Ah,
and
add that bread and butter.
so and when it was, and I spoke to my surgeon, and he said, well, you know, it's about 40 or 50% of the time. And I said, is there any way to prevent this? So I did my own research, looked around, and said, what do I do? Because my surgeon said your weight, you can't lift more than 15 or 20 pounds. So I carry 15 or 20 more pounds all the time when I do stuff. So is there any way to, two things. Is there any way to put that in the checklist? I mean, years ago it was protolized care, right? So was that on the checklist? And two, is there any kind of monitoring in the database of stuff that you look at for hernias and how to prevent them? And I wanted to talk a little bit about this with the PT and the OT earlier on, because I was the one that self-prescribed physical therapy and had to go through insurance to do that. And then it ran out, and I said, well, this chance of occurrence of peristomal hernia exists. So anything you would like to comment on it?
Pilates, I like. That's my solution. No, I'm just not kidding. It is very true, but I hear you. So peristomal hernias, it is I don't even know, like, not talked about it enough. I would say the general data I give to my patients in our pre-operative meeting, which I run from the moment of being in the middle of chemotherapy or getting towards the end of chemotherapy and then gearing up towards surgery, we have an hour-long meeting where people get a very extensive pre-op education material, ostomy kits, regardless if you're eligible for both diversions. So there's a very long conversation, what works and the pros and cons of each. Peristomal hernias, and I disclose this all the time, 50% of patients will have it by 5 years. That is a given number. Out of that 50%, maybe 10% will need actual surgery with a surgical mesh and some kind of a major medical intervention. Now, only very small percentage of patients actually become symptomatic, and even less become, it's an emergency heliport transport to our hospital from bowel strangulation, right? So in the pre-op material, there is a book which I can share with anyone, and a physical therapist put a YouTube video, specifically an hour-long presentation together about ostomy-related pelvic floor exercises. Some of the questions came up, if you have so many peristomal hernias during surgery, why don't we put a surgical mesh in there and just, tuck the ball back in and everybody has a mesh? Well, lots of infections, post-op complications, and a mesh to be placed is about $50,000. So unless you don't need one, obviously it's dollars, but also there can be lots of infections and whatnot related to that. Post-operatively, I think hernias, I would see them develop probably 6 months and over. Some of it is chronic constipation post-cystectomy. I mean, we are connecting two systems together that were never connected together. And there's no other surgery in medicine that connects two things together that should not be connected together, right? So we are connecting GI bowel flora into your ureters and kidneys. Your microbiome permanently changes. We put you on a low fiber, low residue, eat everything you've been told all your life not to eat for 30 days, from Wonder Bread to, processed stuff. And then try to ease your way back into some normal diet that is high fiber, high residue, without having your insoluble fiber blocking up the anastomotic site, causing a bowel obstruction, right?
That's pretty
So
easy.
it's like the oxymoron
Cakewalk.
of all of this. And so I think it's a complicated and complex relationship between hydration, the lifting, having core strength, having the right diet on board, and then all of our patients. At this point, how Dr. Portman and I kind of roll in urology at UCSF, once your abdomen is kind of sort of healed, we are at a 6-week to 2-month mark, we are actively measuring you and fitting you into an individualized hernia belt. Hernia belts are custom made, so some people just wear a belt that is supportive, and that's great. But if you're prone to hernias or lifting or constipated or all of the above, the hernia belt has to be custom measured based on your anatomy. We send those measurements off to a third party called New Hope. New Hope makes custom belts for their patients, and that order is sent then to your vendor, whoever sends your ostomy supplies, like Byram or whoever. And so it is a multi-step process, and I can tell you a lot gets lost in a shuffle until people get their belts sometimes and whatnot. But those are my little things I try to do along the way.
I got a New Hope belt. I'm sorry. So I did get a New Hope belt, which is hard to clear through the insurance company.
Yes.
Then do you prescribe that automatically, or just in situations where you're going to meet that high demand on your core?
I think as I matured, if I may use that word, over my clinical years, at this point, 8.5 years into it, seeing the amount of hernias I have seen, I am very much more active about it, and we talk about it. And even prior to cystectomy, so one of the, have you talk about where your neobladder might be incontinent at night for up to forever, or that will be a challenge, peristomal hernias are discussed with that same openness that this is a thing. Generally, if the hernia is in the beginning phases, I'm able to see that on a CT urogram during your surveillance visit before it gets so big that it's obviously looking like a grapefruit behind your belly. But at this point, I would say it is a pretty active type of approach for us. Yeah.
Hi, Karen from San Diego.
Hi, Karen.
I love the idea of the survivorship clinics. Are they around already? Are there some?
Can you name one?
Survivorship Clinic at UCSF runs under my name, like Mary's name at Chapel Hill.
It's very
So
informal.
there's a couple?
To my knowledge, you speak up if you know of any. I have yet to identify a formal bladder cancer survivorship clinic. There's lots of, there might be, that's not true. There might be one at Memorial. There's lots of other cancers that have their dedicated, full disclosure, I'm the director of our testicular cancer survivorship clinic. But that I was voluntold to do that 14 years ago. So I just kind of put on my plate. It's fine. It's fine. But that's, so in the surveys we've been doing, I don't think anyone has been able to properly identify one. Like my colleagues are like, yeah, Mary does that. No, that is incorrect.
So is there something I can do I go to University of California at San Diego. They're very much into bladder cancer and BCAN and stuff. What can I do to get one of those with them?
All of the money. So change, God, delicate being recorded. Change takes time and buy-in and space and money.
And human
staff
resource.
And resources.
Yeah.
So my suggestion would be plant the seed and start the conversation.
Okay.
Absolutely.
Is there something written about them that I can present to
we
clinics?
we are working on that.
Okay.
And are you on the task force?
No,
You are
but
now.
I'd love to be.
We just got to recruit.
I am writing that on my list. Adding. There's so many Karens. There's so many Karens.
Karen from San Diego.
I know. Adding Karen. Anybody else want to throw their name up here? You just got voluntold. That was rude of me. Hi.
Hi, it's not really a question. I was just like what Bill was talking about, what you guys were talking about before. So before all of even knowing that I had cancer, so I used to work out a lot. I went to my trainer a couple of days a week, played pickleball and everything. So, and I got very strong, and through the whole process, and even after the cystectomy, my first appointment back with my doctor, I was only using the walker to hold all the bags. And they couldn't believe that I could walk by myself. So it does help too, if you can do any kind of exercise and get a little bit stronger before any of the procedures.
Yes.
It absolutely helps in
Yes.
the healing.
That's right. That's true. Thank
You
you.
can put my name on there if you want.
I'm just, and I saw you spell it in a cool way. I don't know who's next. Sorry.
You touched a few minutes ago.
Karens, and you're
Hi.
all wonderful. Hi, Karen.
Another Karen. You touched a few minutes ago on the digestive tract, and I would like to see something added along that line in the survivorship too, because we find that is the biggest surprise in recovery, that our digestive tract is not working like it should, and our doctors are not explaining what really happened during the surgery and why we are totally out of a functional digestive tract. So
Yeah.
can you touch a little bit about what happens with the antibiotics and the anesthesia and everything else that figures in during that surgery?
Sure. I think whatever you're getting intraoperatively, meaning during your surgery, in the pre-op area, during surgery in a hospital, although it's very important, it is a very, very small component of the entire process. And my passion is actually, besides Survivorship, Taskforce with all of you, is microbiome. Because I believe that whatever is in your gut, and we have data from Think Tank, I work with some incredible colleagues, really actually can determine survivorship, response to chemotherapy or neoadjuvant therapy. And then there is the billion-dollar question, those of you who went through cystectomy, why is it that I have patients 7 years out, they never had a single UTI, and then I have the people that I'm treating one after the other, and if you're not on it on a Friday 4 p.m., 100% you'll be septic and in the ER by Saturday night. So I don't really have a whole lot to think, to treat, right? And so I think one of the major thing that happens during surgery, and this is part of our preoperative process, and so this is why we have a 60 to 90 minute meeting with one of us to explain, to look at the anatomy, look at pictures where things get reconnected, what is happening in your gut. I think it would be a fantastic idea and funding opportunity for
Just looking at the lady with
providers.
the purse strings over there.
That's right. So I have, because I've treated so many questions, and I actually have a background in infectious diseases from UC Berkeley, so I'm kind of fascinated with bugs.
That's the quote of the day. Thank you.
I know, right?
Fascinated with bugs.
But so people who undergo neoadjuvant treatment, whatever that is, to actually do stool samples and swabs, once you are done with treatment, and now we have this 4 to 6 week lead time for cystectomy, we do a swab. And then let's say 6 months to 12 months out, we swab.
and we're actually comparing how your gut flora has changed. We can actually map this. My idea would be to actually look at urine cultures and susceptibilities. We know what bugs cause what within the bladder cancer community. We know the big offenders. We know how to treat them. But the billion-dollar question is, how do you prevent it when your bowel is colonized with healthy bacteria? Those guys have been living with you in a symbiotic, loving relationship, digesting your food and producing your mucus all your life. And all of a sudden, we are connecting them to your plumbing. So, it is a pretty big deal. My focus is really on prevention and trying to see down the road. It would be awesome to develop some kind of a high-quality probiotic for people living with diversions for a preventive purpose. There's my proposal.
We love it.
Thank you. But to answer in a different way, I think in a setting of having a urinary diversion, hydration to me is key. Recognizing your symptoms early. So what I've learned over the years is that you wake up, you feel like the train hit you, you don't know what's going on. You wait, then you wait a little longer, and next thing you know, you have pyelonephritis, and you end up in the ER because you need IV antibiotics. So having a conversations in survivorship visits or your follow-up visits, like what are the signs and symptoms I need to watch out for? Because if you don't have a bladder, you're not going to have suprapubic pain. You're not going to have burning when you pee, right? But you will have maybe increased mucus from increased bacterial production of that mucus. You might have foul-smelling urine. Your urine will be cloudy from clear. So whatever your baseline is, there's going to be a change, and you need to pay attention to that and communicate that to your team immediately so they can get your culture. As long as the culture is collected, either from your stoma directly, never from a bag that's been on you more than a few hours, okay? When they send me samples and somebody's collecting across the city from an ostomy that's been on you for 3 days, I'm just not even going to look at it. It doesn't matter. From your neobladder folks, obviously catheterizing, or if you're able to pee, fine. But the data has to exist for us to actually, customize and show your treatment. And then also when there's multiple infections in place, sometimes your immune system, I think, happens more within the first year post-cystectomy. Your immune system is trying to figure out what's going on. And I find those people who are prone to infections, they tend to have them more often than not because of this immune response that is kind of a little bit getting out of proportion, trying to figure it out. So my rule, if we cross 3 infections that I had to treat you 2 weeks at a time, 4th one comes on, once I clear your culture, I'm putting you in suppression for 3 months until we can kind of even the field, so to speak. So antibiotic suppression is a clinical tool that we use. Anybody with bladder cancer, your infections are under the definition of complex urinary infection. Nothing is, so let's say you're a 25-year-old woman who ends up having a UTI post-intercourse, very easy to treat with a 3-day regimen. Anybody with bladder cancer undergoing treatment, whatever that is, it's all under complex. So your treatment needs to be longer, it needs to be targeted. And if we keep having the same offenders come on, antibiotic suppression is giving you a very low dose medication daily, not a treatment dose. It generally is a single strength Streptra, Keflex, or Macrobid. Those are the 3 major medications we use. 3 months, the very least. And then we give you 2 weeks of off to see how you do. Some people make it, some people we gotta go back on it another 3 months, but it's a process until we can kind of clear people for the long run.
But what about antibiotic resistance in that case?
Complex what?
UTI. So I was saying that the urinary tract infections within the bladder cancer patients are always considered complex.
Yeah, but there was something else you said after. You said complex, something.
Not sure. The treatment is more complex, longer. So a general treatment for a person not having a complex UTI is maybe 3 days, maybe 5. I'd say generally 3. So in our population that we treat, the very least is 10 days, but preferably 2 weeks. So one of the things, for example, you go to the ER for a symptomatic infection, and you go home with 7 days of a treatment course. That's just not enough. You need to communicate with your team, you know, A, what has happened, but B, we need to extend length.
Mom's here.
Mom's here.
We can keep this conversation going. I think what we're going to do is we will take this flip chart and put it out there. People can come and
Right.
write things on it if there's something that you're thinking of. But I do want to just make a couple quick announcements. First, I want to thank you both. This is a wonderful opportunity for everybody to really weigh in on something very impactful that has great potential. It's a work in progress. It's going to take a while, but we will be developing the things that need to be developed to assist with having the BCAN survivorship resources. I think it's going to be a wonderful tool for patients to use and for providers to use. We are going to break. I'd ask you to please take everything with you. Oh, I'm sorry. I forgot to put my thing back on. Hang on. I'm going to ask you to take all your stuff out. They're going to come in and make this a lovely dinner. It'll all be a plated dinner.
Nice.
Happy hour is going to be outside. How many of you are vegetarian? A few people identified they were vegetarian
I am.
on their registration. There is a card out there at the table that you'll need to pick up to give to the server so you get the few vegetarian meals that we've set aside for you all. And I'm going to say this now because remember, I want you to make connections. Do not sit back at the same table with the same people for dinner or for breakfast or for lunch. Mix it up. Think about all these people that you need to meet. So now I want you all to scoot out.
I do
The
have
happy
two
hour?
requests,
Oh,
if I may.
yes,
Two
okay.
requests. Two requests, if I may.
One second.
1 second. All hell is broken loose. I have two requests. You can either come to me or write it on here. But I would like to hear, if you're comfortable, from anyone who has had a non-muscle invasive bladder cancer experience, because I think we tend to, in the survivorship space, leave a lot of those concerns unnoticed. I want to know your concerns, and patients who have advanced or metastatic disease. I would like to hear from you all as well about what your concerns are. So please, if you want to either share with me
move that
personally
outside.
or do that, write it up here. Thank you guys so much.
Mary's bringing her notebook with her.
All the things.
So thank you, everybody.
Hi.
I'm a